ITSU, also our colleagues from the Gates Foundation, and all of you members from the CoreNet community. We've been doing these coffee hour sessions now slightly less frequently every month now, but I'm hoping you're all familiar with the ground rules. We are recording this session for anyone who's not been able to join us this afternoon. In case there's an AI note-taking assistant that you spot, please seek consent. If not, I will be removing them from the room. To save bandwidth, it'll be great if you can turn off your cameras and keep yourselves on mute unless you're speaking. Through this session, we will have also the chat window open. So in case if you have comments and questions, please leave them there. And I'll be moderating the Q&A and will be able to take them as I go along. We're also comfortable in speaking both Hindi and English. So in case if you're comfortable in speaking either of those languages, please feel free to use that and we'll be able to translate as required. Great. Just would like to do a quick introduction to CoreNet. CoreNet has been a community of practice that we initiated in 2020 in May, soon after the pandemic emerged. The intention was to foster exchange and collaboration among several research organizations that have been working on researching about the COVID-19 pandemic in India. So far in the past year, we've had about 60 organizations get connected with us. We operate both over email as well as on Slack. As you may know, there's a Slack workspace that we're all part of, which has different channels where people can have conversations. All the studies that are part of the network are also represented on this web repository, which is www.corenet.in, where you can go through and search for studies based on regions, themes, etc. Along with this, we've had members-only coffee hour sessions, which have been for sharing and exchange among the research community, as well as a few research ethics dialogues that we conducted last year. Along with this, we, in April and May, organized the CoreNet conference that had 8 plenaries, showcases, as well as dialogues. And there are 2 working groups that were set up for the community. Coffee hour sessions, as many of you know, are informal conversations. They are intended for the community to share with each other the work that they are doing and bring forth conversations that they would like to have. So in case if you have a research study that you'd want to share with the group or have a particular piece of conversation or a dialogue that you'd like to have, please reach out to us and we'd be more than happy to organize a coffee hour session with you. For today, it's a really special sort of occasion because we are really grateful to have the team from ITSU join us. And this, in fact, has become, I mean, the genesis of this conversation became as we got all interested in understanding how vaccine rollout is happening, what the vaccine uptake and vaccine hesitancy looks like. So as you know, we've had already 2 coffee hour conversations around vaccines. And this is the 3rd one for which we have the team from ITSU that will share with us the behind the scenes conversation on what the vaccine rollout has been looking like. What I'll do soon after this is pass on the mic to Dr. Raj Shankar Ghosh from the Gates Foundation to give us a little bit of the context for how this conversation came to be and what to expect today. And then we'll have Dr. Amrita Singh from the ITSU make a quick presentation and then followed by Q&A with the research community. All right, over to Dr. Ghosh from the Gates Foundation.
Thank you, Rohan. Can you hear me?
Yes, yes, sir.
Wonderful, wonderful. Thank you. So first of all, I just wanted to say that, I speak on behalf of all the colleagues from Gates Foundation who are involved in this activity of COVID vaccination and also in terms of the COVID control. The foundation's activities on COVID vaccination is supporting the government, both at the national level and at the state level with our partners. And we work across 3 broad themes of vaccine supply, supporting the global mechanisms such as COVAX and also the other mechanisms that have, between different kinds of institutions like WHO, Gavi, and the various countries that are working with these institutions for vaccine supply. We also work with some of the major vaccine manufacturers, for example, Serum Institute of India, to ensure that there is a steady supply of safe, efficacious, and affordable COVID vaccines for India and for the world. The second area that we work on is in access, which is to ensure that everyone who needs the vaccine has access to the vaccine, particularly focusing on the marginalized section, the sections which of the society who are disproportionately affected, the areas which we know have are generally left out of the vaccination program. So ensuring that with the government, we are able to reach all these populations. And the third area that we focus on is demand. So supply, access, and demand. In demand, there are, as you will probably hear from ITSU, that there are huge kind of excitement for getting the vaccine. And secondly, also as the vaccine rolls out, there are apprehensions that develop and there is a vaccine hesitancy that we see. All of this is a part of the larger public health science. And in larger public health science, we try to understand all of these through various research programs and try to address them through solutions. This brings me to one of my favorite quotes around research, which is that this quote is by Irene Joliot Curie, and this says that without the love of research, mere knowledge and intelligence cannot make a scientist. Research is critical to a program, and particularly, a program which evolves like COVID vaccination, in which we will have to understand, if I can use the word, the mood of the community, the status of the community, the status of the infection, the transmission of the virus, and accordingly ensure that we are able to make the changes that we need to make in our program delivery. Coming to program delivery, primarily all public health programs, and particularly the programs like COVID vaccination or any vaccination campaigns, they primarily run on 4 E-wills that we talk about. And these E-wills that are there are primarily the first E being efficiency. The programs must be run efficiently. The second is around equity, because if we focus only on coverage, what happens is that we forget the equity piece and the numbers. We are lost in the large numbers of millions and millions getting vaccinated, where small pockets get missed. Therefore, the focus always needs to remain on equity. The third is evidence. And as I was saying, that research gives us evidence, and on this evidence, we run our program. And finally, as we run the program, through this program, the empowerment of the community needs to happen. So therefore, all these 4 wills of efficiency, equity, evidence, and empowerment are the drivers of our campaigns. Finally, from the COVID vaccination program, particularly, we have seen something that we had not really planned very well in the beginning. That is a new group of population who were deprived of the essential resources that are generally available to them, the migrant population, the population which could not really come out of their house to reach the program sites to get their vaccines. Therefore, there is a 5th E, which we always carry a 5th will when we set out on long journeys, and that 5th will here is empathy. So therefore, whatever program we are planning based on our research, whatever research we do, we need to always have that empathy for that particular population which we are catering to. Therefore, these 5 E's of efficiency, equity, evidence, empowerment, and empathy must be the DNA of our research and of our delivery programs. This collaboration between those who are spearheading the program execution, ITSU, on behalf of the ministry, and those who will be generating enough evidence through meticulous research is critical to the program's success. On behalf of the foundation, I wish this partnership I wish this partnership a big success. Thank you so much.
Great. Thanks so much, Dr. Ghosh. This was really useful as context. And as Dr. Ghosh said, uh, yeah, I mean, we are really grateful to be able to bring all of the research partners together with the ITSU on this coffee hour to take this forward. Great. Now I welcome Dr. Amrita from the ITSU. Dr. Amrita is a public health specialist with experience in the field of child health, adolescent health, and immunization at the national level with reputed international and national organizations. She's contributed her skill and expertise in the RCH program, introduction of new vaccines, strengthening vaccine safety initiative under the Universal Immunization Program. And she's also had experience of working and providing support at the national level for the routine immunization program as well as the COVID-19 vaccine rollout. With that, I'd like to kindly pass on the mic to Dr. Amrita, and I will switch slides for you.
Thank you, Rohan. Thank you, everyone. A very uh, good afternoon, everyone. So it's a pleasure to be here and be part of this forum. And I'm really excited to share the journey of COVID-19 vaccination rollout in the country with you all today. And just to showcase where do we stand with all the hard work that has been put in by all those who are involved in the program, be it the one who has been involved in the planning and preparations or the one who has been actually implementing the world's largest vaccination drive on the ground. So just giving a background of who we are, as already said by Dr. Ghosh sir, that he has already given the introduction for ITSU. So just giving you a brief introduction. So ITSU is the technical arm of the Immunization Division, Ministry of Health and Family Welfare, that supports strengthening of the routine immunization system in the country. The work of ITSU is basically organized in three strategic subunits that focus on the key themes of Universal Immunization Program. And these are the program implementation, the EFI Secretariat, and the strategic communication. ITSU not only provides the assistance to the national and the state level for strategic decision making through data analytics, but it also functions as the data custodian for all the immunization related activities in the country. So yeah, so before moving ahead, as mentioned by one of the speakers, that yeah, we have been able to completely done the vaccine hesitancy dossier, and thanks to all those who have contributed towards it. So yeah, may I go to the next slide, please? Yes. So I will, on behalf of ITSU, I will be taking you in a stepwise manner how the COVID started, how the fast tracking of vaccine development was done. Once the emergency use authorization was received, how the planning was done for the actual implementation of the program, and looking at the large cohort, why and how the prioritization of, the large population, I would say, was done. And coming to the introduction part or the actual implementation, it was done in a phasic manner. And followed that, I will touch base on a few important points or indicators, I would say, on what, how, and what has been achieved so far. So we'll mention few challenges also, and how the states and the national level has tackled those challenges. I will be just talking briefly about those. And lastly, of course, the group is as the group is from the researcher forum. So we will be discussing about the possible areas that still needs to be explored, and probably that is one what everyone is interested in. So yeah, but it is important to understand the whole system before exploring the new possibilities. Next, please. So yeah, so the COVID pandemic is definitely the defining global health crisis that is, currently also going on, and the greatest global, I would say, the challenge the world has faced after since a long time. The first case of COVID was reported from China in December 2019, and WHO declared a global health emergency on 31st of January 2020. And subsequently on 11th of March, it was declared a pandemic. Although despite of global efforts to slow the spread of the virus and flatten the curve, that includes, social distancing, travel restrictions, quarantine measures. The disease, it continued to expand its reach, and the novel coronavirus has infected over around 225 million people with around 4.6 million deaths so far across more than 200 countries globally. Although the developed countries like Europe and America, they have also suffered a lot. The developing nations like ours has also suffered severely from the COVID-19, both from the health aspect as well as the socioeconomic aspect. The number of the COVID-19 cases increased at a very high pace in the country, our country, with a total of around 33 million cases till now. So next, please. Yeah, so we all know that there is no definite treatment for these for this virus, and multiple efforts were being done to control the virus, and public health preventive measures were being used for reducing the transmission. But scientists around the world were exploring all the possible strategies to develop an efficient vaccine against the virus. So the process of development of a vaccine is somehow, it takes time because it has to go through trials before they are actually introduced. But looking at the scenario at that time, the development of the vaccine was fast tracked, and as you can see that within an year the vaccine started receiving approvals. Currently also the scientists around the world are still trying to explore more options in the vaccine, as you can see in the table on the right, that the various number of vaccines which are there in the various vaccination trials. So yeah, the vaccines were fast tracked to combat the damage that was being done by the COVID virus. Next, please. So before, it is important that we understand here that till now we have around 6 vaccines that has received an emergency use authorization for our country. So just, trying to re-emphasize that emergency use authorization is basically a mechanism to facilitate the availability and use of medical measures, including vaccines during a public health emergencies, which is, such as the current COVID-19 pandemic. So it basically allow the use of unapproved medical products or unapproved uses of approved medical products in an emergency, so to treat, to diagnose, or to prevent serious or life-threatening diseases. However, these are the conditions when certain statutory criteria has been met, and only then they are being allowed to be used. So yeah, the country has expanded the basket of approved vaccine, and the latest addition in the list has been Zycov-B, that has been approved for the 12 years of age group. The one which has been highlighted, the Covishield, Covaxin, and Sputnik, which are there currently running in the program. However, the others have received the vaccination, and they will receive the approval, and they will be in usage soon. Next, please. So let's see how we planned this whole vaccination program. So the country, we all know that it holds the largest routine immunization program in the world, but the COVID vaccination program was something which was to cater a humongous population of in the country, and it was beyond our regular beneficiary or our target population, that is children and pregnant women. Also anticipating a low vaccine supply initially, a lot of planning was to be done to set the priorities and to do foolproof planning for the execution. So, and one of the achievements in this direction was the constitution of a national expert group on vaccine administration for COVID-19 vaccine, which we commonly which commonly known as the NEGVAC. So the NEGVAC is basically, it guides all the aspect of the COVID-19 vaccine introduction in the country, and it has member representatives from a varied group of varied group of organizations and institutes that form the governance authorities. So high-level coordination at the national, state, and district level was established for the effective cooperation and collaboration among the key departments. Around 19 ministries were involved at the national level, and 23 departments at the state and the district level were involved. And committees at both at all the levels, be it the national, be it the state, district, and sub-district level, they were formed for the smooth planning and execution of the program. Next, please. So another activity that was, done towards the planning was the development of the COVID-19 vaccine intelligence network system, which is a digital platform that provides the end-to-end solution to track the enlisted beneficiaries for vaccination and COVID-19 vaccine on a real-time basis. So it is a platform wherein the citizen to register, schedule their COVID-19, vaccination, and I assume everyone who's there currently on the in the call has been some or the other way use the this COVID system for their registration and scheduling their vaccination. So just to update that ITSU was commissioned by ministry to conduct a dry run of the COVID application under the field situation, and the pilot run was it basically aimed at understanding the practical usage and end-to-end issues for necessary modification and course correction before the actual commencement of the COVID-19 vaccination program. So this was done in 3 states, Rajasthan, Telangana, and Uttar Pradesh, and it provided necessary suggestions for the actual implementation. So in accordance with the prioritization as guided by the NECVAC, and in the next phase of vaccination for the citizens of age appropriate categories that include the 60 plus and beyond that, it was thought of to augment and simplify the process of registration of the vaccination, and thus the ministry came up with the COVID 2.0, which was based on the feedbacks which received during the implementation of the phase 1 of the COVID-19 vaccination drive. So the added features, I would say, was the citizen interface, wherein self-registration was made available in COVID-2, and it was being integrated with the Arogya Setu app, and the beneficiaries can select the vaccination site as per their convenience. Also with this, the option of on-spot registration was also made available. Yeah, next please. Yes, so to roll out the COVID-19 vaccine, as I said, there were multiple preparedness activities that were undertaken, and training was one of the most important one. It was really important to build the capacity of all the stakeholders for COVID-19 vaccine rollout to ensure and successful and smooth implementation of the program. So during the pre-COVID era, I would say majority trainings were being conducted through excuse me, were conducted through facilitated classroom platform. However, the current pandemic, it did not allow us to conduct these training at such a large scale and in a short window of period through the classroom, training. So there were new modalities or channels of training which were leveraged in achieving the humongous task of reaching out to each one who is involved in the process of the COVID-19 vaccination program. And this was also, kept in mind the restriction of travel and the new normals. So this also gave us an opportunity to utilize the various virtual platforms for training in the future as well. So at ITSU, we did, a landscaping of all the available virtual platforms which are there and that can be used for the training, and then they were being leveraged for the actual training, which was done in a cascade manner from national to the sub-district level, and everyone who was involved in the process. Before the trainings, there were multiple modules, and the modules, they aimed to cater to the various target audience. So we had module for the beneficiaries, we had module for the medical officer, for the vaccinator, for the cold chain, for the one who's handling the data. So various modules were prepared, and the various stakeholders or the various health functionaries were trained on the various modules that were developed. Apart from this, as part of the vaccine Metri, which is basically, I would say, friendship sort of a thing. It is basically a humanitarian initiative of the government of India to donate and supply COVID vaccine, which are manufactured in the country to other countries. And apart from this export of the vaccine, we also got the opportunity to participate in the capacity building exercise of these countries, and we shared our experience, how we planned the program and how we implemented it. Yeah, next please. So another integral part, as I said, that for the routine immunization system, an integral part of it is the AFI system. And as part of the preparation activities for the COVID vaccine program, it was important to further strengthen the AFI system, as this was a new vaccine and it was going to be administered to a large population that that comprised of the adult population. So the systems were upgraded to accommodate the COVID vaccination AFIs, and it will ensure that all the vaccination sessions has an anaphylaxis kit, and the sites were linked to the AFI management centers, and they were integrated to the AFI, integration of the AFI application, that is SafeVac. It was done in to the COVID software. Excuse me. So apart from this, systematic analysis of the AFI cases being reported following the COVID vaccine, special committees or groups with participants such as physicians, cardiologists, neurologists, because these are the one who are, they were formed, and so that systematic way, in a systematic way and in a fast track mode, the AFIs reported can be analyzed, and they can be come to a conclusion. Apart from this, capacity building and coordination with the various stakeholders such as pharmacovigilance partners, drug regulators, for improved reporting and causality assessment was also done. And a sentinel surveillance study for the adverse events of special interest has also been in the pipeline. Next, please. So with any new vaccine, and the one that has been developed in a very short frame, it was important to have a robust communication strategy in place to address the various challenges which are anticipated. So the COVID-19, it was already there with the vaccine has issues like the people were eagerly waiting for the vaccine. Some had trust, some were the issues with the having the distrust. So advocacy, AFI crisis management, capacity building, media engagement, social mobilization, all these things were being considered to develop the communication strategy when we talked of the COVID-19 vaccination introduction. Next, please. So to provide the correct and transparent and consistent information on the COVID-19 vaccine and vaccination process, three major areas were focused. One was the vaccine eagerness, so as to ensure understanding and acceptance of the phased, prioritized approach to overcome the concerns of the population who are waiting for the vaccine. Then was the vaccine hesitancy, so that we can build up the public confidence on the safety and efficacy of the new vaccine, as I said. And the other one was the COVID appropriate behavior, so that to maintain and sustain the key preventive behaviors like wearing masks and maintaining social distance, hand washing with soaps during and after the vaccination. So these were the three major broad areas which were focused upon. Next, please. So yeah, with all these preparations and planning, by the NECVAC on prioritization of the group, the rollout of the COVID vaccination program began in a phasic manner, where the first phase included all the health and frontline workers. The second phase of the vaccination drive was initiated from March, wherein in March, and during this phase, all the people above 60 years of age and those over 45 years with comorbidities, they were allowed to take the vaccine. From May onwards, the vaccination started for the 18 to 44 years of age group, and as part of the phase 3 of the vaccination drive, and it is somewhat what we call as the liberalized pricing and accelerated national COVID-19 vaccination strategy. So it has guided the phase 3 of the vaccination drive, wherein also the private hospitals were looped in to expand the reach of the program further. Yeah, so just to add that ITSU supported the ministry in estimating the target beneficiaries for the the prioritization plan, and following which the NECVAC decided the priority groups for the vaccination in a phased manner. Next, please. So yeah, I will not go into the details because it's just the repetition of what has already been spoken with, but with just the dates of the important dates. So maybe we can move further. Yeah, so till now we have just spoke about how the program has, was being conceptualized, was planned, and how it was, brought to the ground. Coming to the how we have, progressed over the last, 8-9 months in our fight against the virus through vaccination. So India, the cumulative COVID-19 vaccination coverage, we have achieved 75 crore landmark milestone on 13th of September. That means, we have administered around 75 crore doses so far, and we have also recorded highest significant achievement has been in the terms of where we recorded a high number of vaccine doses administered in a day, and we crossed the 1 crore mark on 31st of August. Yeah. So as we see that, we are in a, we are increasing on an increasing trend of the reaching out to the to a large number of population every month. Next, please. Yeah, so we'll not go into the numbers, just wanted to highlight that, for the various priority groups, these has been the first dose and the second dose, which has been, as per the priority groups which are there. So we have been able to reach out to this point so far. Next, please. Yeah, with respect to the, if we talk in terms of the full immunization coverage with the COVID vaccination in the country, so around 82% of our priority group, that is healthcare worker, we have been able to fully immunized, and similarly for the frontline workers, around 76% of the, these are the numbers against the target population, which has been, estimated based on the various parameters, and around 76% of the frontline workers have been fully immunized till now with the COVID-19 vaccine in the country. With respect to the various age group that are being, currently in process, so around 7% of the population, which with the age group of 18 to 45 has been fully immunized, and with respect to 45 to 49 of years of age, this would be 59, I'm sorry for the error. So with respect to the 45 to the 59 years of age group, it has been 31%. And so just the whole the priority group is constitutes to around 90% of the total, 90% of the target group, or the, I would say, the eligible population has been fully immunized in the country with the COVID vaccine. Next, please. So herein I've just tried to show how the cumulative vaccine supply, and the coverage has been, has been followed for the last 8 months. So as we see that the vaccine supply in the cumulative, figures, and we have been, trying to increase the coverage as we receive the vaccine. Yeah, next, please. Yeah, coming to a bit, more, the deeper aspects of the program, wherein, so I've herein tried to put in few indicators with respect to the, the state or the place of residence for the beneficiaries. So as we can see that, currently, because this is for the last 15 days, the data which has been shown. So currently, the rural population is something which is, the rural beneficiaries are something which is being picked up quite nicely as compared to the urban. Probably the explanation to this could be that we have already saturated the urban areas with vaccination already, with the involvement of the private sector and all. So yeah, probably this has been saturated, and now the focus and the rural areas, they constitute to be an important and a large cohort is there that lives in the rural areas of the country. So yeah, another program is now expanding its reach to those areas as well, and we are seeing a increasing trend, in these areas. Next, please. Another factor which we thought of, presenting it to the group is based on the gender. So, the COVID-19 pandemic has, once again, exposed how the gender and the other inequalities are interrelated and and the worsen the health disparity. When we looked at the data, we found that, out of the total doses administered, men has been, sharing the 53% of this, and while the women have received only 47% of the total share. Excuse me. Excuse me, I'm having a bad throat, so you might have to listen to a lot of hand coughing. Yeah, so though this gender differential in the COVID-19 vaccine rollout is worrisome, as it is far greater than the official sex ratio. As per the official sex ratio, it is 943. But when we look at the COVID vaccine gender gap, it is 895, which implies that then gender disparity in COVID vaccination is above the difference in the official sex ratio. So this gender gap in the in the ongoing COVID-19 vaccination rollout cannot alone be attributed to the skewed sex ratio, but it can be because of the multiple factors, and these multiple factors could be vaccine hesitancy among the women population, the lower participation in the workforce, lack of access to mobile phones and internet among the women, and of course gender-based discrimination and low priority given by the household to the women health and well-being can also contribute to all this. So as we can see in the analysis of the state-wise utilization of COVID-19 vaccine by gender, it shows that a gender gap varies across states and union territories, and the country it is around 895, which means that only 895 women have been vaccinated in India per 1,000 women. Looking at the state-wise analysis, it reveals that the southern states like Andhra Pradesh, Kerala, Tamil Nadu, Karnataka, they have been performing well with more women being vaccinated than men, while the northern part of the country, northern states like Delhi, Jammu Kashmir, UP, Punjab, and Haryana, these are amongst the one which has been performing not so good with the and they are having the highest COVID vaccination gender gap. So next please. So another aspect, as I said, that we have involved the private sector when we started the phase 3, so as to reach our coverage. However, the the state-wise data on COVID-19 vaccination utilization by the private sector, it reveals that the country's vaccine utilization is slightly more. It's overall the country's vaccine utilization is slightly more than the half, around 58% of the total vaccines that has been supplied. States like Gujarat, Assam, and Andhra Pradesh, they have utilized more than 70% of the vaccine that has been supplied, whereas states such as the states like if I have to name, like Jharkhand, Punjab, then Mizoram, these have reported less than 30% vaccine utilization rate. Next, please. So yeah, as I said, that initially it was the government that has taken a lead in providing the vaccination to the masses, and it gradually expanded its COVID-19 vaccination program through the private sector. However, a declining trend has been noticed with respect to the contribution that has been made by the private sector in the vaccination coverage in the country. So the the data it estimates data estimate shows that the contribution in the month of June was around 8%, whereas it declined in July to around 7%, and it further dipped in August to around 6.8%, with around 93% contribution by the government sector alone. So this decline can be because of multiple reasons, such as the process of registering and placing the orders through the government channels. It is somewhat has to be reported as a very time consuming process. Then there are difficulties in ordering bulk vaccines in advance. So these and there are few private sectors which has poor utilization of the existing doses. So these all have been the various reasons which we have tried to find out and can be attributed to the low participation by the private sector. Next, please. So yeah, the program faced a lot of challenges during the phase of rollout. However, multiple measures were taken as the challenge came up. Measures at the national level and the state levels were taken up to address them at that point only, and not to let it affect the program. So initially, if I have to go in a chronological order, so initially when we started the program, the issue of addressing the vaccine hesitancy and building confidence among the healthcare workers and frontline workers was something which was of concern. This also was, this also was this also had in line with the technical issues which were there with the COVID software, although the software was field tested, but when the actual implementation happened, it had few glitches, few technical glitches in the beginning, but those were managed on time. As the program progressed, and we were able to cater the vaccine hesitancy issue. The other issue that came up for the state and the national level was fixing the demand and the supply issue. So there was a point wherein the demand was high, and we were not being able to supply the desired number of doses to the states to cater to the large demand and the large population. Apart from this, as I said, that there have been multiple reasons why the public-private partnership has, the contribution of the private sector has been a bit low in the last few months. So building that partnership has been a challenge for both the parties at the national and the state level again. And again, as I said, that there have been a few gender issues are there which we are not being able to address currently. So ensuring equity and reaching out to all the individual entities is something which the program also faced. And of course, the recent when the program was open to a larger population apart from the previous priority groups, then one of the issue that came up was the digital divide, because the program was mainly focusing on the digital platform for registration and for the vaccination booking of these slots, and the whole process was basically digitalized. So people who do not have the access or who are not tech savvy, they were having issues of getting them registered and getting the vaccination done. So but for this, the state and the national level did opened up the various other channels by arranging the mobile camps or starting the on-spot registration. So all these issues that I mentioned, they are already has been addressed, but or probably in the process of being rectified. But yeah, these were the issues that we faced during the rollout. Next, please. And as I said, that various innovations during this course of rollout was being done. So just to name a few, that few states, they start. I'm just giving few examples here. So the state, few of the states, they started having mobile teams for the remote areas, because hilly areas, the reach is poor because of the of course because of the landscape. So mobile teams for the remote areas, then the special vaccination drives were being for particular groups, they were being organized. Then cluster immunization strategy in the state of Uttar Pradesh was started. Then pink booths, especially catering to the to women, so that they have a separate and a dedicated vaccination site for their vaccination. It was being introduced in the state of Uttar Pradesh. Then placing the vaccination booth, the location, it has to be population friendly, so that the accessibility never be an issue. So it was being done. Apart from this, focus on small shop vendors and distributors, and the one basically who can be the super spreaders, the one in which we come in contact with them every day. So these were the one who were being targeted in few states, such as West Bengal, then Telangana. They targeted this age group, so this particular population, so that the spread of the virus can be infected if we vaccinate those particular age group. Yeah, next, please. So yeah, coming to the possible areas that that can help us to to shape up the program for further, and to provide us with some certain recommendations. So as I said, coverage in specific groups like age wise, gender wise, or maybe demographic indicators, such as caste or religion, or maybe specific other specific groups. These are the areas, or maybe the tribal population, because in these are the information which we do not get as such in our any digital platform or any other way. So these are the areas which can be explored, and how the reach of the program has been to these particular areas can be assessed, so that necessary actions and strategies can be prepared. Then secondly, as I said, that the program is based on a digital platform, so understanding the accessibility and effectiveness of this digital platform can also be an area of exploration. Whereas we can just assess how this has been helpful for the masses to reach to get themselves registered and get themselves vaccinated. So this will give us maybe in a form of a success story, this can come up, or maybe if there are any issues, then course corrections can be done so as to improvise our platform again. The third area which I think can be explored is because as we are in the phase of having the vaccines for children in the near future. So maybe the parents' perception on introduction of these vaccine in their children is something which we can look for, so that we can plan our strategy accordingly. And lastly, this is completely based on our experience of working with the states currently. So we have been receiving information regarding the from few states that they are reluctant for receiving the beneficiaries are reluctant for receiving the second dose, and this somewhat is not going to fulfill our target of fully immunizing each and every person in the country. So probably these are the areas that why why there is a reluctance for receiving the second dose and completing their vaccination schedule is something which we can explore and plan accordingly. Next, please. So yeah, with this, I end my presentation, and I'll be happy to, and my team here will be happy to respond to any of the questions.
Great. Great. Thanks so much for this very, very useful presentation, Dr. Amrita. I think there's quite a few questions in the chat. I see there's a few questions that Shantanu had that are already answered, but I'll start with the first one, which is from Dr. Priya Nanda at the Gates Foundation. And she asks, what is the data that the government collects presently across these different domains? Does it use results? Does it use results of independent studies as well?
No. So the data which is being used for any analysis is based on the data which is there in the CoWIN platform. So that is our whole and soul data source.
Okay. All right. I see Dr. Ghosh's hand is up. Maybe Dr. Ghosh, if you want to intervene.
Sure. As far as Amrita said, in terms of the analysis that the government looks at, the immunization division generally relies on the CoWIN data and what Amrita described as the ITSU's analysis of the data and feedback. But the NEGVAC has certainly worked with multiple institutions, both in the private sector and in the public sector. Public sector meaning the Indian Council of Medical Research, and in the private sector, various institutions, beginning from ENY to the different IITs and IIMs, who are bringing out constant analysis for the government to consider in terms of making subtle changes and also some very big changes in the program, the big changes around the age groups and all of that, and subtle changes in terms of probably allowing the on-site registration through the CoWIN platform and all of that. So therefore, I would say that the government is looking at multiple kind of research, not only the CoWIN, but also looking at various other kind of research that is coming out of these institutes. Over.
All right, thank you. Yeah, I guess, yeah. The next question is from Monica, who asks, Monica from 3IE, who asks about the immunization among healthcare workers and frontline workers, and what might be reasons for less than 100% immunization at the moment. So any responses to that?
Probably the possible explanation for this is could be, as I said, that earlier there was a few vaccine hesitancy which was there among the healthcare workers and the frontline workers, which was addressed by the ministry in the, starting from the beginning as only.
Right.
This could be, I think, of one of the reasons, and the second reasons could be because as we calculate this as per the priority groups, so. These priority groups has been recently I would say they has been recently revised, so probably because these has been the reasons, because new additions to the priority groups has been done, and that is yet to be covered. So yeah, these could be the few of the reasons that I can think of. Yeah.
All right. All right. We also have Sophia from IDFC who asks, okay, maybe Dr. Ghosh, I'll also pass it on to you again. Please go.
Just to add to what Amrita said, we have a very classic AAA kind of reason for less vaccination, the issue of access, awareness, and apprehension. All of these played a critical role around people being able to get the vaccine because of multiple issues around their access to digital registration or their access to physical sites, awareness that, as Amrita very rightly mentioned, people were confused whether they are in the age group or they are not in the age group, and apprehension, which generally translated into vaccine hesitancy. But one thing that we need to really keep in our mind, that whenever there has been an uninterrupted steady supply of the vaccine, the health workers have not failed to vaccinate the population, target population. India has actually done very well in terms of the vaccine utilization. So whatever vaccine has been supplied has been utilized very well. And wastage has been also not to the extent that we were expecting it to be. So we will say that, the coverage has been affected by the AAA, phenomena that we see in the society, but also that supply, whenever it has been good, there has been a good kind of demand and also acceptance.
Great. Thanks so much, Dr. Ghosh. I'll just do a couple of more questions. I see we already only have 6 minutes to go, but please keep adding your questions into the chat. We'll try to see if we can go about 5 to 10 minutes over time, but we'll also be documenting these questions and collecting responses from the ITSU to share with all of you in case we run out of time on the call. So please keep adding your questions. We have another one from Sophia from IDFC Institute, who asks whether you've been able to overlay geographical disparities on COVID vaccines as against variations that you see in the routine immunization program. So are the geographical disparities in vaccination rate similar to those observed for routine immunization?
For this question, so to be honest, currently we have not analyzed it, this aspect of routine immunization disparities and COVID-19 vaccination disparities, but just wanted to highlight that the reasons for the variation in the vaccination status for the particular the states, it are different from the one which we encounter in routine immunization. So these could be because of the supply side issue in particular state, and this would be because of the demand side issue, and the various other reasons like floods, the natural calamities. These all are add up to the various reasons of the ups and downs in the coverage, and the variation in the coverage in the various states. But yes, currently we have not been in we have not analyzed it in that perspective, but yes, the various reasons, as I said, are these.
All right, thank you. Abhishek from ICRW asked specifically around how there was a disparity with vaccine uptake among women, and with that respect, are there any provisions made for enhancing this uptake for vaccines among women, particularly so between for pregnant and lactating women?
So as I said that there are a few states which has come up with the innovations of organizing special vaccination sites, arranging the vaccination booths at at a convenience place wherein everyone, including women, can be part and can get themselves vaccinated. So various innovations and at state level are being done to address this issue of the gender disparity in the COVID vaccination. Yeah.
All right. Yeah, thank you. Will be useful to look that up, but in the interest of time, we have one more question from Sushanto from IPAS Development Foundation. He says we're using age-wise distribution of vaccinated persons frequently. Are we also using any other type of social demographic variables to understand vaccine acceptance?
Yeah, so as I said, and that the basic data which we are taking for analysis is something which we get from the COVID is our data source. So eventually, currently, we do not get any information regarding the socioeconomic aspect of the beneficiaries apart from the one which we have presented. So we get information regarding the gender of the beneficiaries. We get information regarding the rural and urban aspect of the the place of residence we can get, but beyond that we are not collecting any information that is there in the COVID. So it is somewhat currently we are not looking at into that aspect, and this is something which we would also like to have from this group, if they can do some field studies and they reach out to that particular group, such as tribal population, or maybe a particular specific groups, so that we can also get information on the same. Yeah, over.
All right, great. I'll quickly now pass on to Gunjan from BMGF, who will also introduce us to colleagues from the TSU and the Clinton Health Access Initiative. Over to Gunjan.
Yeah, thank you, Rohan, and thank you, Dr. Amrita, for the detailed update and the question. So we have some of our colleagues from the TSUs in, I think, Bihar and UP both, and the CHAI colleagues who have been supporting the rollout across UP, Bihar, and Madhya Pradesh. So if there are any state specific, I know we are more or less at time, but if participants do have any specific questions related to these states, then would request Dr. Deep, Colonel Bhatia, or Meenal, if they are still online, to possibly answer them. Back to you, Rohan.
Hi, Rohan. Can I ask a question to Gunjan?
Yes, please, Shantanu.
Yeah.
In case if the others have questions, please feel free to use the chat window or raise your hand and I'll call upon you. Thank you.
Yeah.
Please go,
So,
Shantanu.
yeah, so based on some of the analysis I have done, those are also co-win data. So I have seen that in MP, the coverage of second dose, I mean, the first dose coverage is not bad. It's not one of the lowest, but the second dose coverage in MP is surprisingly lower. So any thoughts on that? What's happening in MP on the compliance? So it could be a distribution of vaccines, could be a reason, like if it's only Covishield, it could be that, or it may improve with time. I don't know. So.
No, thank you, Shantanu. And so the second dose coverage definitely has been a concern, not only across MP. If you look at even the cumulative figures which Dr. Amrita had shown. So it is a concern, and I think something which the central government has repeatedly prioritized and also issued directives to the state government. So there might be multiple factors. I'll possibly touch on a couple of them, and then we'll pass on to Meenal, who might give us more specific answers as regards MP. Specifically, when the dosage schedule changed, I think 12 to 16 months or weeks gap is a pretty long time. Secondly, with the vaccination actually picked up more or less when the second wave was ongoing. The population cohorts in the general population started at that time. And then the cases have also come down drastically. So we were thinking, and I think that is something which we have noted on also, as to how the evolution of the pandemic might also have had impact on full immunization. The third thing specifically, if we look at the geographic distribution for MP, UP, and Bihar, there is a lot of both intra-state, interstate, in and out migration which has happened. So that might also be a factor, but all these are still conjunctures, as we saw since Dr. Amrita was also speaking on the gender part of it. So the gender, the coverage specifically for women dipped during and immediately after the second wave. That was when the vaccine procurement policies were changed and the overall vaccine supply was a challenge. We saw a higher proportionate dip amongst females as compared to males. But coming back to the the second dose, I think as the ITSU team has also said, this is something on which I think we still need to get more concrete answers to. I think there is a lot of psychology or human behavior which is also at play. So if Meenal has anything to add, and possibly Shekhar is also there on the calls, if something from their end. Meenal?
Thanks, Kunjan. So the second dose is really a pertinent question these days, and that's definitely for MP, but it's there in other states also. Like Gunjan said, there's no 100% correct answer. There is a series of factors affecting this. It could be complacency, it could be the inconvenience that you've had after the first dose, not having enough information, a series of things. What is, I think, one of the things that MP is doing and our team is supporting is the active volunteer-based mobilization for second dose, which has seen some traction, but ever since the beginning of the campaign, we are seeing that special initiatives are required to really mobilize people for the second dose. Even in, you'll see that there's a specific campaign that says second dose is the real dose, just to get across the message that you're not fully protected until you have the second dose. So this is quite a, and again, to come back to MP, there is a program which actually gives volunteers points, like a sort of a video. If you mobilize these many people, every day you'll get a list of 5 people, and you mobilize them, you get certain points. And these are sort of your civil defense volunteers and young people, colleges, who are sort of volunteering to mobilize people based on their phone numbers. So these meetups are happening frequently. There are specific days allotted that this day, let's only do second dose. There are specific sessions that are dedicated. This is only a second dose session. Again, we don't know. There are obviously various reasons as to why second dose is lower. And it's not only because the time gap is high. Different sessions have actually been given lists that, okay, you have these 100 people who've not turned up. By every session side that you have these many people who are due, not turned up. From travel to fear to just complacency, various different factors are at play over here. Thank you. Over from my end.
Okay. Thanks, Meenal. I'll quickly go to Dr. Preetu
and Dr.
Yeah, thank you. So I just want to add, I mean, initially we have analyzed the data where the second dose has started in 18 plus, and and we realized that the major portion of the second dose due was due to the co-vaccine, and that was basically due to the supply constraint. They had a problem with the few of their lines in the manufacturing unit. So that was now slowly I think it's improving. So there are many multiple reasons, and one of the major reasons that initially we when we did analysis of the data, we realized that this is because of the co-vaccine, and this is because of the supply constraint of co-vaccine. Over.
Rohan, if we can also have Dr. Deep, I think he has worked very closely on this in UP. So if there are some insights from him, I think that will also be helpful for the group.
Yes, please. Dr. Deep?
Thank you, Dr. Gunjan. Good evening, everyone. So on the gender issue, we actually, because we have been tracking it quite closely for the past few months, and what we have noticed, and like UP was one of the first state which started pink booths for women in each district after we had presented this stark difference in number of doses being administered way back in June. We have kind of improved from where we had a 42% of the doses that were being administered to women to over 45% of the doses, cumulative doses right now. But one of the things that we have observed over last few months is that we were able to correct this not just because of the pink booths, but whenever we did the cluster approach, which was like basically taking the COVID vaccination centers closer to home, on those days, now we are having a few big days each month in UP where we administer over 2 to 3 million doses. And on those days, we are observing that over 50% of the doses are being administered to women, which kind of gives an insight that the geographical access was an issue earlier when we were doing vaccinations only at healthcare centers. And there was no other reason which was being assumed earlier. So that has been one thing that we have noticed, and that is and it is getting corrected. So there is no additional strategy that we are applying, but it got the gender differences were corrected when we went for cluster approach. So that is something that I wanted to add here. Thank you.
Thanks so much, Dr. Deep. That was really insightful. In the interest of time, I'd like to just quickly do a vote of thanks. Thank you again to all of you for making it to this session. Thank you to the team at ITSU for not only putting this together, but sharing it with the research community. And thank you to Dr. Gunjan and colleagues at the Gates Foundation for facilitating this conversation. I think it's quite evident that we have a whole lot of questions, and that this is only the starting point to be able to create a more sort of easier stream between evidence and the work that the ITSU does. And as CoreNet, we'd be more than glad to make these connections for all of you. So in case from the ITSU team, if there are any specific requests for the researchers, please feel free to share them with us. And among the researchers, if there's any pieces of evidence, specific people that you want to connect to, we'd be more than happy to do that. Please write to me or Babita, and we'd be more than happy to take these conversations forward. With that, thanks again, everyone. Thank you to Dr. Amrita for presenting, Dr. Preetu, everyone. Thanks very much. Have a good evening.
Thank you to you too, Rohan, and the team for coordinating and managing.
Thank you for the opportunity. It was a great experience. Thank you.
Thank you.
Bye. Thank you.
Thank you, everyone. Bye.
Bye.